Let's talk about skin biopsies. They're one of the most common procedures out there, but when you get to the coding, things can get a little messy. So today, we're going to crack the code on CPTs 11102 through 11107. We're going to clear up the confusion and make sure you're coding every single procedure with total confidence.
Okay, let's dive right in with the single most important question you have to ask yourself before you even look at a code. Was this procedure diagnostic or was it therapeutic? Seriously, getting this one thing right is the foundation for everything else. It literally decides if you're even supposed to be using these biopsy codes to begin with.
So let's break down this core principle, because in the world of biopsy coding, you have to understand the provider's intent. It is absolutely everything.
What I love about this is how clear it makes things. On the one hand, you've got your diagnostic biopsy. The whole point, the only point, is to grab some tissue to figure out what's going on. That's when you reach for codes 11102 to 11107. But on the other hand, you have therapeutic removal. Here, the goal is just to get rid of the lesion. Maybe it's bugging the patient or it's a cosmetic thing. Now, any tissue sent to pathology here is just, well, it's incidental. It's a byproduct of the removal. So you never use a separate biopsy code for that.
And this is the perfect example to make it stick. Think about an irritated skin tag. The doctor shaves it off because it's bothering the patient, right? The main goal is to treat the irritation, not to diagnose some big mystery. So that procedure is a therapeutic shave removal. You're looking at the 1130-100 series of codes. It is not a diagnostic biopsy, even if that little piece of skin ends up in a jar headed to the lab. Okay, so you've confirmed the procedure's intent was 100% diagnostic. Great. So what's next? Well, now it's time to open up our coding toolkit and get familiar with the 3 specific types of biopsies you'll be dealing with.
This table is such a great bird's eye view. We've basically got 3 main players: tangential, punch, and incisional. Now, the key thing to notice is that each of these techniques has its own pair of codes, a primary code for the first one and an add-on code for any extras. Let's take a closer look at each of them. First up, we have the tangential biopsy. I want you to think of this as a very superficial procedure, a shave, a scoop, or a scrape. It's a partial thickness sample, which just means it's not going all the way down through the skin layers. And remember, the purpose has to be diagnostic and diagnostic only.
Next is the punch biopsy. This one uses a neat little tool that's kind of like a tiny cookie cutter to get a full thickness, tube-shaped sample of skin. And here's a super important detail. Simple closure, like a single stitch or some steri strips, is already baked into this code. You don't get to bill for it separately.
And rounding out our trio is the incisional biopsy. This is when a scalpel is used to cut out a full-thickness wedge of tissue. It's often for getting a look at something deeper down. And just like the punch biopsy, don't forget, simple closure is always included with the code.
So we know the what, but what about the how many? Right? What happens when a provider does more than one biopsy in a single visit? This brings us to a really fundamental system in coding, the whole primary and add-on rule.
The logic here is pretty simple, but it is super strict. The primary code, the ones ending in 2, 4, or 6, is only for the very first lesion. After that, every single additional lesion biopsied in that same session gets an add-on code, the ones ending in 3, 5, or 7.
And hey, if there is just one thing you remember from this entire explainer, please let it be this number: 1. You can only, ever report one primary biopsy code per patient per session. That's it. It's a hard and fast rule in the CPT guidelines. No exceptions.
All right, enough with the theory. We've got the principles down. Now for the fun part. Let's actually put these rules to the test and walk through a few real-world and sometimes tricky coding scenarios.
Okay. Let's start with a nice, easy one to get warmed up. A patient comes in, and the doctor performs 2 tangential biopsies on 2 different spots.
So, how do we code this? It's a really logical process. For that first lesion, you use the primary code, 11102. And for the second one, you use the add-on code, 11103. So your final coding is just 11102 once and 11103 once. See? Simple as that.
Okay, let's kick it up a notch. What happens when you have biopsies that use different techniques? For example, say a patient has 1 punch biopsy and 2 tangential biopsies. Now here's where a new rule comes into play, and it's a big one. When you have different techniques, you have to figure out which one is the highest level procedure. That one gets to be your single primary code. A full-thickness punch biopsy is more involved than a superficial tangential one, so it wins. The punch gets the primary code 111104. That means the two tangential biopsies both become add-ons, and you'd code them as 111103 times 2.
All right, time for the final boss of biopsy scenarios. A patient gets one of each, one incisional, one punch, and one tangential, all in the same visit. How in the world would you code this one?
The principle is exactly the same. You just apply the hierarchy. The incisional biopsy is the highest level technique here, so it grabs that one and only primary code slot, 11106. The punch biopsy then has to be an add-on, so you use its specific add-on code, 11105. And finally, the tangential biopsy was also an add-on using 11103. See the pattern? One primary, and then you just match the right add-on code to each of the other techniques.
Okay, we have covered a ton of ground. Let's wrap this all up with a quick lightning round of the most important things to remember. These are the key takeaways that are going to help you avoid those common coding mistakes.
Let's lock these in. Number 1, simple closure is always included. Don't even think about reporting it separately. 2, you only report one primary code per session. 3, the highest level technique wins, and it gets to be that primary code. 4, a simple scraping or tape stripping is not a biopsy. And 5, never bundle separate lesions. Each one gets reported.
And let's bring it all the way back to where we started, because honestly, it's that important. This quote right from the guidelines says it all. If the main goal is treatment, like a full excision, then any tissue that gets analyzed is just considered part of that bigger procedure. It is not a separate, billable diagnostic biopsy.
And just one last, quick but really important note. Everything we've talked about today is for skin biopsies. As you can see here, other parts of the body, like the nail, the lip, or inside the nose, they all have their own unique codes. So always double-check your CPT manual for those specific areas.
You see, at the end of the day, this isn't just about memorizing a half dozen codes. It's about understanding a system, a way of thinking, a logic based on diagnostic intent, a hierarchy of techniques, and that primary plus add-on structure. And you know what? This framework pops up all over the place in the CPT world. So the real question I want to leave you with is, where else in your daily coding can you apply this logic to crack the code?